method with which you can enter. So you know everything. One book, $100, you know everything. All it does is enhance communication. That's chiropractic.
Do you use ultrasound?
No, I got a $70,000 machine, and I've done 1 million injections. I can do it. I don't need it. It's approved. It's fun. It's a nice toy. But if you're good,
Yeah, you've got your palpatory skills of being good enough to be able to do that. But once they are,
the Germans don't use ultrasound. What does that tell you? Yeah, they say no to your anatomy.
All right, I think we got it.
we're ready.
Ready?
Okay, perfect.
We're ready to rock.
I'm cool. I'm out of your way. Thank you very much.
Okay, we can take our seats. We have a treat. We have Dr. Halassa, all the way from Maryland. He earned his medical degree at Tripoli University in Tripoli, Libya in 1998. Dr. Halassa was a researcher in immunotherapy at Baylor University in Texas, a clinical associate at Compassionate Pain Management in Delaware. He has published nitro medicine articles with Dr. Hamlin at the Wellman Center for Photomedicine in Massachusetts. He is the Chief Executive Officer and the founder of Nitro Medicine, LLC, in Maryland. Dr. Halassa is a frequent speaker at venues such as the International Society of Optical Engineering, the American Society for Laser Medicine and Surgery, Nitric Oxide Society, American Academy of Anti-Aging Medicine, ISLA, Florida Academy of Pain Medicine, Photobiology Society, Boston BioLife, and now the American Osteopathic Society of Rheumatic Diseases. The best of the bunch.
Yes.
Bring you Dr. Halassa.
Thank you. Good evening. My name is Dr. Halassa. I'm the founder and author of Nitro Medicine. And we're going to talk about pain. And the reason we want to talk about pain because we do have problem in managing pain, or we have a certain percentage of failing in managing pain. So how much of you are managing pain? All of you? What is the successful rate of your pain management? You can say 70, 80%. And then the 20% are not responding. Oops.
Wardrobe malfunction.
So we have 20% not responding to the pain management, right? And I would like to share with you some of cases of mine that we try with all kind of interventional payment procedures, and still they are not responding. I have a case, a female at the age of 40, and she has a lumbar pain, lower back pain, diagnosed with a disc prolapse and radiculopathy, so her disc is pinching the nerve. And we did all the interventional pain management. We did steroids, we did the PRP, think about it, but no response. And their EMG nerve conductive study shows there is radiculopathy, so yes, there is a pinching nerve. And she's qualified to do the surgery, so she did the surgery, she did the discectomy and spinal fusion. After that, she came back to our clinic, and still she has pain. She has the shooting pain going down to her legs, and it's not responding even with surgery. Another case, we have a lady, she has discogenic pain. She's at the age of 70. And we did all the pain procedure, the intradiscal injections of steroids and PRP and all that, and still, she's not responding. I think everybody here have those cases, right, where you do everything and they don't respond. And sometimes you think, well, they may be faking the pain to seek for narcotics and all that. But the reality, they have real pain, and they are on pain. And those are the 20% of those cases where they are not responding to our interventional pain procedures. And there are many more. There are a lot of cases out there where they do knee replacement surgery, right? And the percentage of success or respond is the same thing, around 80%, and you have 20% are not responding, and they still have pain in the knee, although there's no knee there. It's only metal, right? So the question is that are we actually treating those patients? Are they responding to the pain procedure that we're doing, or they are not responding? In our world of pain management, and because of our training, we are focusing mainly on neutralizing the peripheral pain generators. And we are actually missing the centralized pain. So this neurosurgeon who did the surgery for this patient is actually, it's not a failed procedure. It is a successful procedure, and the patient did respond. And also the patient that I inject her disc at 70 years old, she did respond. But what exactly the response is neutralizing the peripheral pain generators, but not the central pain. So what we are missing here is that those patients develop what we call centralized pain. Any patient or any person who has chronic pain, peripheral pain generators, right, whether it is fracture or disc problem or arthritis or whatever it is, the origin, those chronic pain or chronic peripheral pain generators, they can develop into centralized pain. They can cause changes in the brain and the spinal cord, neuroplastic change, wiring of the brain, where the pain generators is not anymore in the peripheral, but it's in the central. So when we did all this procedure, we did fix the peripheral pain generator, but we missed the central pain. So in other words, all those patients who we are treating with pain and they have chronic pain, peripheral pain generators, they develop centralized pain. Their brain change, there will be neuroplastic changes in the brain, and they start lowering the sensitivity of the pain, which we call centralized pain, and they having central pain generators. So when we are doing all these injections, we are fixing the peripheral pain generators, but we are not fixing the central pain. So in other words, when we do all this peripheral pain generator and we manage them, we will find out 80% respond because their central pain regress back and normalize those neuroplastic changes where there is no more central pain, but that 20% continue having this centralized pain. And so in our mindset that we think that those patients are not responding, but they are responding to the peripheral pain generators, but not the central pain, because we did not do anything about the central pain. So in order for us to understand central pain versus peripheral pain, we need to understand the neuroanatomy of the pain, and we need to understand the pathway of pain and pathophysiology of pain, and understanding how peripheral pain generators leads to centralized pain and how we can manage that. So these are my team of doctors who are adapting my protocols, and the definition of central pain generator is a neuropathic pain that happens when the central nervous system does not process the pain signal properly. Peripheral pain generators is a nociceptive pain that is not part of the nervous system and caused by inflammation or injury such as osteoarthritis or rheumatoid arthritis or burn fracture. So there's two kinds of pain. There's the peripheral pain generators, and yes, we are treating that, but we are not really managing the central pain. So we have this 20% of those patients, they continue having the central pain. So we fix the peripheral pain, and normally when you fix the peripheral pain, your central pain will go away. Your neuroplastic changes of the brain will normalize, but there are 20% they will continue having this central pain. Their neuroplastic changes does not normalize, and we think that they are not responding to our pain procedures, but they are. They are responding, but they are responding only for their peripheral pain generators because that we are managing, and we are missing what? The central pain. So the reason of all this failing of these procedures that we think is because we are missing managing the centralized pain. So we got here about 20% of patients with osteoarthritis who have their knee or hip replaced continue to have chronic pain, and the pain has likely become centralized. It's no longer caused by inflammation or injury. Now the pain is driven by dysfunction of the central nervous system. So the pain is coming not anymore from your joint, but it's coming from your brain and from your spinal cord, specifically the dorsal horn and the amygdala. So let's go ahead and understand the pain, understand centralized pain, and how those 20% of those patients, their centralized pain does not go away. 80%, it goes away when you fix the peripheral pain generators. Your central pain goes away with it. But 20%, they continue having the central pain, and then we think, oh, you know, we did not do the good job with the patients, and we start giving them narcotics and spinal cord stimulator, morphine pump, which is unnecessary procedures. So if we understand that those 20% did respond to the pain procedure that we did, the peripheral pain generators, we neutralized them, yes, but we did not fix the central pain, and that's the reason of those patients are still suffering from pain. So let's start understanding how peripheral pain generators, chronic peripheral pain generators, leads to centralizing pain. And understand the whole mechanism of the pain pathway. Once we understand central pain, peripheral pain, then we have better understanding of how to manage pain in general, centrally and peripherally. So let's start with let's say, for example, if I touch a flame or flame of a candle, what would happen? I would have some pain generators, right? Pain signals coming up, coming all the way to the spinal cord, which is going through the peripheral nociceptive neurons, and they will go to the spinal cord, as you see here. See there? And then what would happen? You would have the spinothalamic nociceptive neuron taking it all the way to the hypothalamus, to the thalamus, as you see here, right? All right, so see here, and then it goes where? To the thalamus. And when it goes to the thalamus, that's where we feel the pain, right? That's all right. All right. Then from the thalamus, it will go to the amygdala. That's where we feel the severity of the pain, right? It's also the questions of the pain. I feel pain. All right, so how severe is the pain? There's also the questions that we ask the patients, right? And that's when the signals goes to the amygdala. And then what will happen? Then it goes to the hypothalamus. And the hypothalamus gives you what? The response of the pain, the behavior of the pain, right? Which is the fight-flight reactions, right? What other things? Turning your head to the side of the pain, turning your arm away from the pain, all those pain reactions. Valsalva maneuver is another one. Right, Valsalva maneuver helps to decrease the pain. We're going to see the mechanism of that. All right, and then what would happen? The pain signals, those pain signals will go to what? To the somatosensory cortex. And that's where you can localize the pain, right? You ask the patient, where's your pain? Oh, my pain is in my hand, right? When the signal goes into the somatic sensory cortex. And then we ask the patients how the pain feels, right? The quality of the pain. And they say, what's burning pain or stabbing pain? That's when the pain signals goes to where? To the somatic sensory association area, right? So we can see it here, how it's moving to the somatic sensory association area. And then all those pain signals will be stored where? All the events of the pain will be stored into what? Into the hippocampus, right? That's where it's stored, all the information of the pain and the events related to the pain. All right. And then signals will go back to the amygdala, right, from the hippocampus, and then there will be signals going to your prefrontal cortex, right? All right. And that's the memory is informing your cognitive, your conscious, that there is a pain, what you will do. Your cognitive and your conscious was, and according to the memory of the, you have experience of little pain, right? They will say, well, your cognitive say, well, this is a little pain. Don't worry about it. It's something will go away according to the past experience that we have, which is being stored in the memory. So your cognitive, your prefrontal cortex, will start sending inhibitory signals to the amygdala and say, hey, calm down, everything will be okay. And the amygdala will start sending inhibitory signals to the prefrontal cortex, but who's going to be winner here? Because the pain is trivial. Your cognitive, right? Your conscious will say, this is okay, don't be panicked, and it will suppress your pain behavior, right? You don't be reactive when the pain is little, right? All right, but what would happen if the pain is massive and severe? If you put your hands in a stove and that's very hot, then you would have severe pain, massive pain signals going to your dorsal horn, right? Bombarding your dorsal horn. See that signals here? And then it goes to where? To the thalamus, and that's where you feel the pain. And then it goes to where? To the amygdala, and that's where you feel the severity of the pain. Those are the questions that you ask the patients, right? About the pain. And then from the amygdala it goes to where? To the hypothalamus, where you have the behavior of the pain, the fight reactions, right? Heart rate will increase, respiratory rate will increase, and all this pain behavior. What other pain behavior? Crying, screaming, right? Turning away from the site of the injury, turning your head to the site of the injury. All those reactions, all those reflexes, it's being mediated by the hypothalamus here, right? Okay, so it goes to the and then the pain signals coming from the thalamus to your somatosensory to localize the pain, and then to the association area to recognize the quality of the pain, right? And then all of this will be stored into the hippocampus, right? There. And then the hippocampus memory, all the memory of this past experience of this pain will be sent to the amygdala again and sent to the prefrontal cortex. And your memory will say, well, this is severe pain. We have this pain before. It's very strong. You will not sleep at night. And you have to be worried about it, right? So the amygdala will aggravate the whole reaction of pain, sending to the hypothalamus all those information, so you react to the pain, and you start crying and screaming and pulling your hands. And what other things that we do to manage pain? Valsalva maneuver. And we're going to explain how Valsalva maneuver help us to decrease the pain. You remember when you have pain, severe pain, you're holding your breath, eating like this, squeezing, right? All right, we're going to see how this helps to activate the descending analgesic pathway. But we have here a fight between prefrontal cortex and the amygdala. Amygdala will send signals to the prefrontal, to your conscious, and say, this is severe pain. It's very severe. It's like 9/10. And your memory from the hippocampus will say, you know, we have this before. It's very big. You will not sleep at night. It's going to bother you almost 2 to 3 months, give you all these worries, right? And your prefrontal cortex will try to suppress it. Like if I put my hand in my stove, I don't want to be embarrassed in front of you and start crying and screaming. So my prefrontal cortex will start sending inhibitory signals to the amygdala to say, control your behavior of pain, don't react, don't be panicked. But the amygdala is, because of the signals so powerful, will send inhibitory signals to the prefrontal, to your conscious. And who's going to be winner here? Your amygdala, your subconscious, or your conscious in this case? Your subconscious. So I'll start crying and screaming and yelling because I cannot control it anymore, right? And the other thing that I will do Valsalva maneuver. Have you experienced that, right? When you have pain, you hold your breath and then you squeeze. Why we do that? Because when you do this and you squeeze, you're increasing the central pressure, the carotid artery central pressure, doing that, right? Taking air in, and then you squeeze, you press on your carotid arteries, and in the carotid arteries there's baroreflexes, right? You remember those baroreflexes? When they get activated, they slow down the heart, but the other things about these baroreflexes, they send signals and activate the descending analgesic pathway and increasing the enkephalin, which help to stop the pain signals. Right? So that's the mechanism of how your Valsalva maneuver helps to decrease the pain. I think everybody experienced that. When you hold your breath in your brain, you're actually increasing the enkephalin, your endorphins, and when you do that, you're putting the brake on the pain signal that goes to the brain. We're going to see that in the animation. So see here, this is where the fight between cognitive, prefrontal cortex, and the amygdala. See how they're fighting? Your conscious is inhibiting the amygdala, calming it down, saying, hey, don't be reactive, don't be panicked. And the amygdala is sending the pain signals and saying this is serious and this is big, so they are inhibiting what? The prefrontal cortex here. Okay, now, the other thing is that, as we say, we have the signals that the baroreflex, as we know, it's going to be activated, right, because of the Valsalva-maneuver. And when it's being activated, they will be activating the descending analgesic pathway. This is the descending analgesic pathway. So, baroreflex from your carotid blood vessels goes all the way up here to the hypothalamus and to the midbrain, to the salivary nucleus, and then they will send signals to the descending analgesic pathway. And the descending analgesic pathways is the periaqueductal gray area and the lucus ceruleus and the rostral ventral medulla. Those are the descending analgesic pathways. They are made from serotogenic and norepinephrine or noradrenergic neurons. And see, they will be activated. And we see it here. See how this descending analgesic pathway is being activated by baroreflex here. And they will send signals to inhibit the pain signals, right? The descending analgesic pathway, they will activate the enkephalins, and they will inhibit the upcoming signals. See, this is, let me show you the signal that goes all the way down. See that? Alright? So that's the activation of the descending analgesic pathway, which will activate this enkephalogenic, which is here, and that will inhibit the upcoming pain signals, right? It's like a brake, putting a brake on a pain signal. Okay. See that? And that signal there and everything from it's releasing of the endorphins. All right. So what will happen here? Because it's a burn, it's, let's say, for example, it's 4th or 5th or 3rd or 4th grade degree of pain. So it's a big lesion there. So you will have what? Massive pain signals going all the way to your spinal cord, right? Bombarding your spinal cord. And then what will happen here? See that? The pain signals goes away. And who's carrying the signals? The C fibers, right? And then they will eventually activate the central nociceptive neurons. And how are they going to activate the central nociceptive neurons? They release what? Glutamate. And the glutamate, how they work? They open up the glutamate receptors, the calcium channels, and the calcium will go in, as you see it here. I can show you the process here. See this here? Alright, so this is the glutamate, and they open up glutamate receptors, right? And it goes what? Calcium influx. See the calcium, the yellow ones? And then the calcium, when it goes in, they activate the NOx enzymes. When they activate the NOx enzyme, they generate the free radicals, which is the red color. See that? And then those free radicals, increasing the free radicals, we call that increasing the redox potential, redox signaling, will activate your central nociceptive neurons, transcriptions, proteins, transcriptions, right? The expression of the gene expression of your proteins, of the structural and functional of the synapses. So what will happen? You will have sprouts of dendrites growing and connecting with this upcoming nociceptive neurons, the C fibers. I'll show you how this sprout of dendrites is coming out. Here, see that? Right? Okay. So what happened here? I increases the number of the synapses between the peripheral nociceptive neuron and the central nociceptive neurons, right? And when you increase the number of the synapses, what will happen? You lower the threshold. And what will happen when you lower the threshold? You're increasing the sensitivity of the pain, right? This is rewiring. This is neuroplastic change. This is progressive neuroplastic changes. And then what will happen to this patient, right? When you press in the area of the injury, they will have what? Hyperalgesia. Which kind of hyperalgesia? This one is the primary hyperalgesia, right? So primary hyperalgesia is due to this neuroplastic changes that's happening, which goes sprouts of dendrites that connect to the peripheral nociceptive neurons with the central, increasing the number of synapses, lowering the thresholds, increasing sensitivity, so when you press on the side of the injury, you will feel pain, and that's primary hyperalgesia. Now, is primary hyperalgesia is normal or pathological in this case? What do you think? Normal. So if you have a fracture, right, you need the hyperalgesia.
you need the allodynia, the secondary hyperalgesia and allodynia. Why? So you don't move your arm, so you allow your arm to heal. If we don't have this hyperalgesia, central pain sensitization, which is part of sensitization, then we start moving our arms, and then the bone will not heal. So it's being designed that we have this central pain sensitization, along with this peripheral pain generator, which is the fracture itself, right? Okay, so it is normal now, but it's going to be abnormal if the bone is being healed and this central pain sensitization continue. That become what? An abnormal, right? Because normally when the bone is healed, there's no peripheral pain generators, your central pain sensitization has to restore back to normal. All this wiring will break up and return back to normal. That's the normal. But we have a percentage of patients, right? They end up having central pain. So after they're healing their bones, they say, well, you know, I still have pain. But there's no really fracture there. It's been healed. Yeah, but I have pain. There's fracture there. And that's the central pain, right? All right. So the other thing is that we will have continue bombarding the spinal cord with pain signals and opening up the calcium channels by glutamate, increasing the free radicals by stimulating the NOx enzymes. And these free radicals, when it goes up, the physiological, or we call them free radicals, they stimulate the gene expression of the synaptic proteins and functional proteins, and they develop what? Dendrites, sprouts of dendrites. That will be connecting with what? With the nociceptive neurons, the peripheral one, that's not coming from the site of the injury, but from the surrounding site of the injury, right? And then we will have something that's called what? Secondary hyperalgesia. So let's say we have an injury here, burn is here, but when I touch here, I feel pain, right? When I press here. And that's because your central neurons now is being connected to this nociceptive neurons that's coming from here, although it's not being activated because it's away from the burn. And this is called what? Secondary hyperalgesia. And this is all part of the central pain sensitization. Okay, so we're going to see that here. Here we activate the gene expression of the proteins of the synapses, and here we're developing the synapse that will be connecting to so this is the primary hyperalgesia, right? So here, and then goes again, and bombarding, activating, and you will see here another increasing you see another sprouts of dendrites coming out, and they will be connecting to the C fibers that's coming from the area that is away from the site of the injury, and we call this what? Here, let me show it to you. Here, did you see that? You see those dendrites that's coming out? Let me show it to you here. And where they are connecting to the nociceptive neurons that's coming from the sites, not from the injury, but from away from the site of the injury. And we call this what? Secondary hyperalgesia. See where I'm touching there? Away from the injury, and the patient's pressing there, and the patients have pain, right? That's a secondary hyperalgesia. And it's all part of central pain sensitization. So I'm just trying to make central pain sensitization real. Not something that's, in the books, but something that you can see. All right. Again, we are continue bombarding with pain signals, right? And what will happen, you will be activating the gene expressions of the synapses of the dendrites, and they will form, see here, a dendritic sprout that will be linked to tactile neurons that's coming from your arm. See this one here? I'll show it to you. See this one here? See, this is another sprout of dendrites, and what they are touching or connecting to the tactile neurons, the A fibers. So what would happen when your central nociceptive neuron dendrites is attaching and sprouting and attaching and forming synapses with your tactile neurons, with your peripheral tactile neurons? Then you would have something that's called what? Allodynia, right? So just touching like this, and the patients feel pain. That's called what? Allodynia. Taking a feather and just touching it, and the patient, that's what's happening to those patients, right? When they have fracture or severe pain, they end up having all those three things. Again, all the central pain mechanism is part of protection, right? Defensive, it's physiological. As long as you have the peripheral pain generator exists there, right? Okay, so what happened here when you are touching and doing something like this and activating and getting more pain signals going in, bombarding the spine, the dorsal horn, right? It will reach to the point where the free radicals that's being generated, they will leak out from those nociceptive neurons, and they will activate the glia cells. You know the glia cells in the spinal cord? And what will happen to the glia? You will have what? Neuroinflammation, neurogliosis, right? And those neurogliosis, what would happen? They generate free radicals, inflammation, so you have inflammation in the spinal cord, right? And those free radicals, they can open up the calcium channels and depolarize your central nociceptive neurons. So what's that mean? That means even without any external stimulus, without touching anything, you have pain signal generating from your spinal cord, and what we call this phantom pain. So when it gets into neuroinflammation, too much of free radicals, well, those free radicals will open up the calcium channels, they will bypass the glutamate, then you will have pain generated from within the spinal cord without any external stimulus. So you don't need any external stimulus, and that we call what? The phantom pain. See those free radicals coming up from the, and called what? The phantom. And they will aggravate the nociceptive progressive neuroplastic changes. We saw that, all the sprouting things. But those free radicals that's coming from those neuroglioses, they actually cause regressive neuroplastic changes in the descending analgesic pathway. So those free radicals, they will cause inflammation, they will cause progressive neuroplastic change in the nociceptive neuron, and the neurons that's carrying the pain signals, but they will cause what? The regressive neuroplastic changes in the descending analgesic pathway. The descending analgesic pathway is responsible to put the brake. So what would happen if you decrease their number of their dendrites, right? You will aggravate the central pain sensitization. All right? So you can see very clear those free radicals causing progressive neuroplastic change in the nociceptive neurons, but it causes regressive neuroplastic change in the descending analgesic pathway. Okay, now let's go and see the second thing is we know this central pain sensitization can lead to peripheral pain. Central pain leads to peripheral pain. So we know from what we learned that peripheral pain leads to what? Centralizing the pain by changing the neuroplastic of the nociceptive neurons, right? But also continue and chronic central pain can end up turning into peripheral pain in the form of complex regional pain syndrome. Have you heard about it? When patients, they have burn, right? And then they heal, but they still have pain in the site of the burn, and then they progress and they become complex regional pain syndrome. Or you saw patients with fracture, they heal, but they continue having pain coming from that area, and that's a central pain, and then the central pain progress into complex regional pain syndrome, where the central pain become what? Peripheral pain. So peripheral pain can become what? Central pain, and central pain can become peripheral pain. Let's see how the central pain turns into peripheral pain. What's the mechanism of complex regional pain syndrome? Okay, so let's go back. Here's the pain signals. Let's say if we have pain signals going all the way up, and let's just show it again. Okay, let's say we are putting a feather, touching it, allodynia, right? All right. So what would happen here? We have the pain signals goes all the way up to the amygdala, to the same process we saw with thalamus, and then to the amygdala, and then to the hypothalamus. You see here when it goes to the hypothalamus here. All right. And then when you activate the hypothalamus, what would happen? Hypothalamus, there is two parts of it, sympathetic and parasympathetic, right? Here, they will activate what? The sympathetic, okay? So, central pain, those pain fibers of pain pathway can activate what? The sympathetic fibers. See when it activates the sympathetic fibers? All right, and show it here. And this is the sympathetic fibers activation. Did you see that? Okay, so when you activate the sympathetic fibers, what will happen? you would have vasoconstriction, right? Norepinephrine goes vasoconstriction. Okay, so you have what? Cyanosis and the blueness of the complex regional pain syndrome. What are the things that norepinephrine does? It stimulates the NOx enzymes in your tissue, generate free radicals, and the free radicals induce inflammation. And inflammation causes what? Vasodilation. So you have what? Redness. Is that what happened in complex regional pain syndrome? You would have paleness, redness, and bluish, right? All three, which is called vascular instability there, right? That's because of overactivation of the sympathetic fibers. See that blue and red color here? And the patient would have what? Allodynia. Those patients, if you start touching them, what would happen? The complex patient, they start screaming and yelling, right? And if you have a feather like that, and you put it here, that's that. And even by patients, when they have the experience of the feather touching, and then the next time they come, and when you show them the feather, what would happen to them? Yeah, they start screaming and crying, right? Why is that? Okay, we're going to explain why, okay? So go ahead and say, okay, we're not touching those patients with the feather, and they have this pain signals going up, okay? And what would happen to those pain signals? They would activate a central, it's called habenula. What is the habenula? Habenula is the hate center, okay? So, the pain signals, I'm going to show it to you. Here's the pain signals. Follow the signals here. It goes all the way up to the spinal cord, right, to the spinal thalamic, then to the thalamus, right, to the amygdala, to the hypothalamus, and then to the habenula, which is the purple one. Did you see that? Right? So what would happen when you activate the habenula, the hate center? The hate center will send inhibitory signals to the love center, which is the tegmental area. I'll show you the love center, which is here. Okay? And when you inhibit the love center, what would happen to your dopamine? Because the love center releases dopamine. Your dopamine decreases. Anything that decreases dopamine makes your body what? Move away from it. Right? Anything that activates your habenula, your hate center, it will make your body move away from it because it will lower the dopamine, and when you lower the dopamine, it will cause your body to move away from it because eventually you'll be sending signals to the nucleus accumbens, and the nucleus accumbens will generate the movement that will make your body to move away from it, because if you move away from it, your dopamine goes up. And that's what's happening in all our decision here. We have habenula, hate center, love center in the brain. And that actually control all of our movement, all of our next movement. Let's say, for example, you're here sitting with me here, hearing this hardcore science, which is very difficult to process. But because I think you're a geek doctor like me, you like the hard thing. You want to understand it, right? And challenge it. So there's two options, whether leaving the room, having fun, having coffee, or staying here. But your choice to stay here and listen to this hardcore science means that staying here increases your dopamine, right? But if hardcore science reduces your dopamine, your choice will go to leave the room. And so what makes us, or what gives us our decision, is all about the dopamine level. Whatever increases our dopamine, we go to it, right? We move toward, when we seek whatever increases the dopamine. And we move away from anything that lowers the dopamine. Okay, let's go ahead with habenula and VTA. Anything activates the VTA, the love center, we move toward it. Anything activates the habenula, the hate centers, we move away from it, right? All right, so that's what's happening when you give a patient or a baby or a child, when you give them a chocolate or a bowl of salad, what they will choose? A bowl of chocolate, right? Because there's sugar, and the sugar increases the dopamine. Salad doesn't have sugar. So they would choose what? The chocolate. But if you cognitively teach those babies that chocolate is bad, it will cause your teeth loss, it will cause you disease and sickness, it's not good, right? Or salad is healthy, it's good, the broccoli is healthy, your cognitive and your memory will work together, and they can modulate the habenula and the VTA, the love center and the hate center, where all these memories, good memories about the salad, will activate the VTA, the love center, and inhibit the habenula to the point where when you give the child, again, after training and cognitive therapy and modulating their habenula and VTA signals, they will be choosing what? The salad over the chocolate, right? And that's also the same mechanism we use to treat patients with drug addiction, because we know that drugs increase the dopamine, right? So how we manage drug addiction cognitively? We tell them about the drug is bad, you lose your family, you'll end up losing your job, no money. All this will be stored in the memory, and they will be activating what? The habenula. When you start thinking about what the drugs, eventually those patients will be switching or being stopping taking those drugs. Of course, you need to give them CBD or something that helps to their dopamine to go up so they can listen to you. You cannot give cognitive therapy to a cold turkey patient because their mind right now is all about seeking that drugs, right? Which we're going to study that in the coming slides. All right. So what will happen here when you activate the habenula, right, which is the hate center? It actually causes even more pain. So remember when I put the feather in front of those patients, right? In addition to they are running away from it, they say, doctor, you know, I feel a lot of pain and discomfort. Why? Because habenula send inhibitory signals to the descending analgesic pathway and inhibit it. What will happen if you inhibit the descending analgesic pathway? You decrease the enkephalins and endorphins in your spinal cord. The patient will feel more pain. So you say, doctor, you're making me more pain. I feel now more pain just by showing the feather, right? Because this feather thing is being recorded in their memory, and those memories activated every time they see the feather, which will activate the habenula. Okay, so I want to show you how the habenula activates the descending analgesic pathway. So here, see, this is the habenula. So see, this is the habenula inhibits the VTA, as you see it here. Okay.
Where's the habenula? Okay.
This is the habenula and this is the VTA. Okay, so it inhibits the VTA, right? Both the habenula center and the VTA, love and hate, they send inhibitor signals to each other. All right. So, and then we see the habenula is sending what? Inhibitor signals to the descending analgesic pathway, which makes you what? Feel more pain. Okay, see that here? All right. And those descending analgesic pathway, they are what? Serotogenic and noradrenergic neurons. And then they will activate the encapsulogenic, which is the black one here. The black neuron, that's here. Okay, so what are the things we are going to learn from this? We're also going to learn about the post-traumatic stress syndrome. So what happened in your dorsal horn, this neuroplastic changes that happened in the dorsal horn, it did happen also in your amygdala. So your amygdala is becoming what? Hyperactive. Too much of neuroplastic changes, and they can fire spontaneously. And if the amygdala fires spontaneously, what will happen? The amygdala will activate the whole circle of your memory, your hippocampus, your sensory, and then you will have the flashbacks, right, of the post-traumatic syndrome, and it's because of progressive neuroplastic change that happened in the amygdala, and then you have all this flashback and also the experience of the pain, because it will activate the whole events of the pain, and you will have the patient, which is the post-traumatic stress syndrome. Now we understand how pain and injury leads into post-traumatic stress syndrome. And if you see here, this is it, okay? So this is the amygdala, overactive, see here? So they send signals to all the circuits of the pain pathway, the somatic sensory, the sensory makes you feel it. And you experience, you know, those patients, they feel the pain because they're activating their somatosensory cortex and the association area and also the memory, and they see the whole event in front of them. They hear it, they smell it, they see it, and that's because of the stimulation of the hippocampus, as you see it here. All right? Okay. So, amygdala neuroplastic and post-traumatic stress syndrome, as you see it here. And then, if you ask those patients, can you control it? They say no. Why they cannot control it? Because your amygdala is sending inhibitory signals to your cognitive. And they cannot, in their cognitive, your conscious control cannot control this behavior. So it is out outside of their conscious control. Did you see? Remember when I said the amygdala and your cognitive are in war and they're sending inhibitor signals to each other? Okay, so how we manage central pain, what we do with central pain. We understood that, okay, so those patients, we thought they're not responding to the intervention pain, this 70-year-old lady with discogenic pain and the 40-year-old lady with radiculopathy pain and those knee replacements. We thought before that they are not responding, but the fact they are responding. But what they are responding, you are neutralizing the peripheral pain generators, but the central pain is there. Normally, their central pain has to be regressing back to normal when the peripheral pain goes away. But those patients, they don't. They continue having this neuroplastic change. Their brain genetically, they cannot restore back. And that's why we say, oh, it's a failed procedure. It's not really a failed procedure. You just did not understand that there's other part of the pain, you did not fix it, which is the central pain, which this patient, which is 20%, they continue having it. Normally, it regress, gets back, but those 20%, they don't. So what would happen to those doctors who did not understand the central pain? They will continue injecting the peripheral side and over-injecting and doing all those procedures, the RFA, the morphine pump, and digging more and more and causing more harm to the patients, and then they give them narcotic. What would happen if you give them narcotics? Okay, yes, you relieve the pain for a short period of time, but narcotic is a pro-oxidant. It will aggravate the central pain. It will cause all this regressive neuroplastic change in the descending adjacent pathway and progressive neuroplastic change in the nociceptive neuropathway. So short term, you're numbing it, but long term, you are increasing it. So what would happen to those patients? They become like zombies. And what will happen to those pain management centers? They will be the site of pain. They will be generating the pain in a state of relieving the pain. So this is what we're going to learn, that narcotic, yes, they numb the nociceptive neurons. How they numb it? They open up potassium channels, and when you open up potassium channels, you hyperpolarize the neurons, and you numb them. But what's the problem with, see here, see this is the narcotic here, opioid, I'm showing it to you here. All right, see how it's going there? And they open up potassium channels, and they hyperpolarize the neurons, and they numb it. But what's the problem is that they open up the calcium channels. They activate the NMDA receptors. When you activate the NMDA receptors, what will happen? You have calcium channels opening. When the calcium channels are opening, calcium goes in, activate the oxygen enzyme, generate the free radicals. And what will happen to those free radicals? It will aggravate the neuroplastic changes, the progressive one. It will activate or stimulate the neurogliosis, the inflammation. Right? So opioid causes inflammation, right? And it will cause progressive neuroplastic changes and causing what? More centralized pain. And really, we're not really fixing those patients. Short term, yes, long term, not. Okay. So what we need to do for those patients then, how we can solve it? Give them CBD. CBD is an answer. CBD works the same like opioid. They numb the nerve, they work with the same receptors. Well, they work on the CBD receptors, but they do the same. They open up potassium channels, they hyperpolarize the neuron, but what's the difference? CBD is antioxidant. It blocks the NMDA receptors. It blocks the NOx enzyme. So what would happen? You decrease the free radicals, so it's antioxidant. It also, CBD helps to decrease the inflammation of the neurogliosis. And what would happen here? You relieve what? You manage the central pain. So those patients, give them CBD and then do the cognitive therapy, right? So here's the CBD. See that here? Inhibiting the NMDA receptors. And also CBD blocks the COX enzyme, LOX enzyme, decreasing the inflammation, okay? And what happens when you have too much of free radicals? You would have what? Too much of oxidative stress. Oxidative free radicals cause oxidation of the immunoreceptors and make them what? Insensitive, right? So that's another mechanism of the adduction and of the opioid. So increase opioid receptor. So, but when you do the CBD and you decrease the free radicals, and you eliminate those free radicals, what will happen? Those opioid receptors will open up, right? And that will help to increase opioid receptor sensitization and treat adduction. Okay, what are the things that we're giving to the patients besides CBD and opioid? The mainstream medicine. We give tricyclic antidepressant. Why? Because they increase the norepinephrine. You remember the descending adjacent pathway? Also, we give them serotonin reuptake inhibitor because the descending adjacent pathway is serotogenic neurons. Do you remember that? All right. We give them GABA. Why? Because it blocks the NMDA receptors. We give them ketamine, we give them non-steroid inflammatory drugs, which helps to decrease the inflammation, yes. We give them steroids. Well, the problem with steroids and the non-steroid, you know the problem, right? Problem with the vascular and causing the kidney problems, right? Causing all these complications of steroids. So you cannot give steroids for a long time. You cannot give NSAID for a long time, so you cannot really manage them with those. Okay, but then we have the B12, how it works. B12 is good, right? It helps to block the NMDA receptors, okay? You give curcumin, curcumin is good too, right? Helps to decrease the inflammation. Also, it helps to increase the expression of antioxidant enzymes, the catalase enzymes. We give alpha lipoic acid to neutralize the free radicals, right? And we give them exosomes. Why exosomes? Because exosomes are very rich with RNAs that express antioxidant enzymes and anti-inflammatory cytokines, which help to decrease the free radicals, right?
You give them systemically or locally?
I would give it intranasal, the best. For neurodegenerative disease, central pain, intranasal, sublingual is good, oral is good, but the intranasal bypass the metabolism, gets into the brain. Oral, metabolized in the liver, not good. Sublingual, not that much. Intranasal is the best option.
How about IV? We're talking exosomes, right?
Exosomes, intranasal too, for those patients. Just, exosome is nanosized. It will go through. You don't even to inject it. Just get sprayed in the nose. Along with vitamin B12, along with CBD, and you got it from that. Okay, so this is just show all the mechanism here. The other thing the problem with mainstream big pharma products, all of them, the GABA, the steroid, anti-inflammatory drugs, all this, but they are not being tested against redox metabolism. So all of them can interfere with mitochondrial function. What would happen if you interfere with mitochondrial functions? You're increasing the free radicals. So short term, all this big pharma is good, but in long term, what would happen to them? They're not working anymore, right? Why? Because they increase the free radical. They cause oxidative stress. Steroids, GABA, ketamine, all of them, they interfere with the mitochondria. Now, mitochondrial function is very important to improve it. How we can improve it? With simple thing, light, photomedicine, photobiomodulation. Have you heard about it? Light is another way of treating central pain. As you see it here, I'm shining the light on the mitochondria to improve the function of the mitochondria, decreasing the free radicals. I think the time is up. No? 5 minutes?
Once he gets in, you got time.
Okay, you have questions?
Does your CBD have to have THC to be effective for this?
I don't have a CBD myself, but yes. If you go to the companies, I think mixing it with TCH is better, the full spectrum from my side, because you get the whole real balance of the redox. But if you do the isolate, because of the regulations, go for that. There's another way of managing central pain using alternative to CBD. It's called palmitide ethanolamide. It's an alternative to CBD as well, but it's not CBD, it's alternative and works the same like CBD. And that's in Europe, it's very big, palmitide, because it helps central pain, neuropathy. The other thing you can use is methylene, palmitide oil, palmitide, like palm oil, palmitide oil, ethanolamide. So that's another alternative to CBD if you have stigma with CBD. And the best thing for central pain is methylene blue. Have you heard about methylene blue? Okay, so methylene blue, I'm doing a lot of work on methylene blue. Actually, I'm working on treating coronavirus with methylene blue using photodynamic therapy. You can treat Lyme disease. It is the best redox molecule, buffer molecule, methylene blue. I want you to read about methylene blue. Search it in Google, say methylene blue, oxidative stress, methylene blue cancer, methylene blue coronaviruses, methylene blue pain, methylene blue osteoarthritis, they inject it into the joint. I want you to read about methylene blue. It's a miracle molecule, and the more you read about it, you'll be like, wow, this is just crazy. Okay, any other questions?
This is great stuff, but I've seen this for years. But one thing that's overlooked by you guys is there's always a dental component to this disease. And I've had patients with RSDs and stuff, and you take out a root canal or infection, and it goes away.
Right.
So there's more overload on the same system you're talking about that gets undiagnosed.
Right. So let me explain this because this is very important. When you manage oxidative stress, it's like a tire with many holes. you cannot patch it with one hormone. So oxidative stress means you may have leakage of the gut and leaking the bad stuff, the free radical generators, those toxins of the bacteria. And that can aggravate all kind of oxidative stress-related disease, all chronic disease, Parkinson, whatever you say, chronic inflammation, whatever it is. Teeth, if you have inflammation and you have pathological free radicals, yes, it will aggravate the whole chronic disease out there. All the chronic diseases, the pathophysiology is actually abnormal redox metabolism. All of them, they are oxidative stress-related diseases. So this is the field that I am bringing to the table. I'm trying to connect all the dots, why the acupuncture works, because it modulates the redox locally, and also that when you do the acupuncture, it activates the descending adjacent pathway. Why we're doing massage therapy, why we're doing fixing the dental, why we're doing the gut, why we're doing detox, because we are fixing the root pathology, which is the oxidative stress, which is pathological free radicals. Needs to go down to physiological level. Now, free radicals is not bad all the way. We need a physiological level to kickstart and stimulate your proliferation, differentiation of stem cells in your body, so you need it. Otherwise, if you don't have the free radicals, what will happen to your body? Weakness, and you will end up losing your bones and muscles. That's what happens when you go to the moon, right? There's no gravity, no stress. What will happen to your body? Atrophy, right? So you need a physiological level of free radicals. But when it goes to the pathological, it actually regress and cause all the problems that we have and aggravate all the chronic disease out there. So this field is called oxidative stress-related diseases. If you join me and join my academy, I'm working with Dr. Clearfield, and we can learn more about it, and we can connect the dots, and then we can communicate with each other with a common language, which is the redox metabolism. Done?
Thank you.
All right.
We have a short presentation by Dr. David Kahn from Quantum Cellular Medicine. This is a non-CME presentation, so we'll be hearing about the products and whatnot. I have to do a little quick thing here, and
He wants me to talk, and he'll stick it in. All right, can you hear me okay? See. Testing. Okay. Testing, can you hear me? It's okay? No? Oh, no. I can hold it. All right. Maybe I'll just talk loudly and you can hear me. All right, great. This is a computer screen.